Cool. So thanks for joining, guys. Today we're doing the second PED session of the final series. So I'm Catherine and I've got Olalaide with me as well. So let's get started. So today we're going to cover some PEDS respiratory conditions, seizures, dermatology, GI issues, cardiology, and metabolic disorders. As always, we'll do 10 multiple choice questions. We'll give you a little bit of time to give you what you think the answer is, and then we'll go through an explanation as well. All right, so let's start with question 1. So a 2-year-old boy presents with a barking cough, hoarse voice, and inspiratory stridor. He's febrile but alert with mild respiratory distress. What is the most appropriate initial management? Okay, so moving on to the answer if everybody's ready. So the answer here is oral dexamethasone. So this question is talking about croup, which is really commonly seen in children. So croup, or a longer version that I'm not going to try and say on a recorded teaching session, is a common viral respiratory illness. So it's often in children that are aged 6 months to 6 years, and it's most commonly seen in around the 2.5 kind of age group. So what it is inflammation and edema of the upper airway, particularly the subglottic region, which leads to airflow obstruction. So if you were seeing these children in GP or in A&E, you'd probably see that they came in with a barking seal-like cough. They have a hoarse voice. They've got inspiratory stridor, so especially when they're crying or upset. They have a low-grade fever. Their symptoms are often worse at night as well, so you'll often hear parents say that their seal-like cough gets worse at night, and it's often preceded by cough or cold kind of symptoms as well. So it's most likely caused by parainfluenza virus, so especially type 1, which is kind of most common thing in your exams, but it can also be caused by other viruses as well. So this is just a classification of croup severity. Just something covering up the mild category, but it's kind of, yeah, obviously as it gets more severe, the cough gets worse, the stridor gets worse, the work of breathing gets worse, and you often see retractions and things like that when it's really severe, and they get more distressed, obviously the more severe it is as well. Cool. So we've obviously said that the first line management is oral dexamethasone. So the steroid helps to reduce the airway inflammation. It improves symptoms as well, and it reduces the need for children to be put in hospital. You use that for mild to moderate cases. So if you're in GP or something like that, it would be okay to manage that like that in the community. For moderate to severe croup, we use nebulized adrenaline and dexamethasone as well, just because the adrenaline helps to work quickly to temporarily reduce the airway edema, especially if the child's in distress as well. And then you can give them the steroids on top of that as well. And obviously as well, supportive care is really important, especially if the child is agitated, trying to keep them calm, giving them oxygen if needed, and they might need a hospital observation for a little while as well, based on how severe their croup is. Cool. So moving on to question 2. A 6-month-old infant presents in winter with a cough, poor feeding, and increased work of breathing. On examination, he has wheeze and crackles. What is the most likely diagnosis? Amazing. So if we move on to the answer for this one. So the answer here is bronchiolitis. So bronchiolitis is most common in children that are aged 1 year or less. It's particularly common during the winter months as well, often because children spend more time inside and are more susceptible to catching things. So it's typically caused by the RSV virus, which is a big thing for your exams as well. It's quite commonly asked. It presents with kind of cough, cold symptoms, feeding difficulties, especially in that age group, fast breathing, and the widespread wheeze and crackles really is something that differentiates it from other things. So you don't have to give any antibiotics or anything like that to a child with bronchiolitis, and the management is supportive, so oxygen and fluids if needed, but generally they just need a little bit of TLC and some kind of paracetamol and things like that to help them along as well. So moving on to question 3. A 7-year-old girl is brought in after a seizure. She has brief staring episodes, eye fluttering, and was unresponsive for 10 seconds. What is the most likely diagnosis? Amazing. So well done, everybody. Absent seizure is the correct answer. So absent seizures are a type of generalized seizure. They're often seen in children aged 4 to 10 years. So the peak incidence is around 6 to 7 years old. They're characterized by brief episodes of impaired awareness. So like the staring episodes where they're not responding, and they're often mistaken in school-aged children for daydreaming or inattention as well. So I've just written down the first line treatment as well. It's important to note that carbamazepine and phenytoin should be avoided in absent seizures because they can make them worse as well. But the prognosis is generally very good for children. So around 65 to 85% of children tend to outgrow the absent seizures by the time that they're teenagers, but a small percentage may go on to develop juvenile absence epilepsy or myoclonic epilepsy as well. But the prognosis generally is thought to be very good. Okay. So moving on to question 4. A 1-year-old child presents with itchy, dry, red patches on the cheeks and extensor limbs. What is the most appropriate first-line management? I've just put a photo on there as well for an example of the rash that you're seeing as well. Okay, so we'll move on to the answer. So the answer is C, so corticosteroids and emollients. So this is an example of atopic eczema. So it's really common in infancy. And the important thing in infants is that it affects different areas to adults. So it affects the cheeks often and the extensor surfaces as well, rather than the flexor surfaces that you kind of see in adults and older children. So the management is about the same as it is in adults. So regular emollients and topical corticosteroids, so 1% hydrocortisone during flares as well. But yeah, the main point of this question is to try and identify eczema in younger children because it does present differently as well. Cool, so moving on to question 5. A 6-year-old child presents with golden crusted lesions around the mouth and nose. He's otherwise well. What is the most likely diagnosis? And this is just a photo as well for an example. Amazing. So well done, everybody. The answer is D, so impetigo. So what impetigo is a superficial bacterial skin infection. So it's often caused by staph A or strep pyogenes. So it presents with kind of honey-coloured crusts generally around the mouth that people kind of tend to notice it. And it's treated with fusidic acid cream. If it's all over the face and different areas as well, you can treat it with oral antibiotics as well. But generally what you'd see in the community is that some fusidic acid just tends to kind of sort the mild cases out, and it's quite common as well. All right, so we will switch and go from here.
Yes, guys, can you all hopefully you can all hear me. So we're going to go through the next question, which is just a continuation of other pediatric topics. So a 6-week-old child presents to the GP with non-bilious vomiting following feeds, which is very forceful in nature. They have lost weight and appear hungry post-feeds. Mum tries to demonstrate what happens during the feed, and when you examine the baby, you're able to feel an abdominal mass. What is the most likely diagnosis in view of the current history? I'll put the poll up now. So, well done. The answers are correct. So it is pyloric stenosis. So we'll move on to the next slide. So essentially, I think, the classic history of that is projectile vomiting. I kind of avoided using the word projectile vomiting because I think at the moment people see that, they kind of think, oh yeah, it's pyloric stenosis. But usually in exams, they give you classic symptoms, but don't necessarily tell you, in the words that maybe you're used to. So projectile vomiting was one thing that gave it away. They're hungry post feeds as well. And the age range as well also gives you an idea sometimes. I actually had this in my final year OSCE. And so, this is something to be aware of in terms of, what certain features look like in terms of the presentation. So the palpable olive-shaped mass is also shown on the screen as well. They might also ask you things like blood gas interpretations. And so the typical picture is hypochloremic, hypokalemic, metabolic alkalosis. So that's one thing to bear in mind, and that's something they could easily present you with an ABG. And then, expect you to interpret that in an OSCE setting where this question is being asked. And then in terms of management, they might ask you how you would describe the procedure to the parent of the child who's about to have this procedure, for example, which is the pyloromyotomy. Also, I've just included a picture of there. So pylorus obviously is that part between the end of the stomach and the small intestine. And so that gets kind of thicker, which is the hypertrophic part. And because it's thicker, the passageway gets narrower, which is why it's a pyloric stenosis. So you have a hypertrophy of the pylorus. So they might ask you to actually explain that to a parent, which is what we had to do in our OSCE. So it's a good topic to know, easily testable on different elements, so worth knowing. And also in your GP placements, you could easily see this. So it's just something worth bearing in mind. So we'll move on to the next question. Can't see any questions about this, so we'll move on to the next one. So a 5-year-old child presents to the GP with their parent as they're concerned about soiling with feces, despite the child being previously continent. On further history taken, you're informed that there was no delay in passing meconium. The child was born at full term and there were no medical issues, no weight loss or delay in developmental milestones. What is the most optimal option for pharmacological management of your most likely diagnosis? So I'll put the poll up and let you guys vote. So someone's gone for C. Well done for being brave and committing to an answer. I'll just give about 10 more seconds before I reveal the answer. Okay, so we'll move on to show the answer. So the answer is actually B rather than C. And this is one of those things where it's about exam technique and actually reading the question where they try to catch you out. So the most likely diagnosis here is idiopathic constipation. So we've tried to kind of explain to you that, you know, constipation isn't something that you should, you know, sorry, if you just go back to the previous slide, Catherine. Thank you. So yeah, so essentially this is constipation. It's idiopathic. I've kind of tried to elucidate the fact that from the history taken, you know, there are no red flag symptoms, which we'll go into in future slides. So this is just pure constipation. And whilst, you know, kind of everything here is something that can be used for constipation, the question why C is wrong is because we've asked for what optimal pharmacological management option. So usually first line, you know, increase fluid and fiber intake. But when there is, you know, an issue like this where you want to address pharmacologically, then the answer obviously isn't going to be increased fluid and fiber intake. And the rest of them, they're all plausible options. Some are less likely to be used in a 5-year-old. But why it's Lexido is kind of explained in the guideline that's within the QR code on the screen. So if you want to have a go, scan and go through that. But if we get to the next slide, I've just kind of captured the main things. So yeah, so constipation pathway for primary care. This is from the NHS England document that's in the previous QR code as well. So, you know, part of your assessment, you want to rule out certain red flags, which we'll go over in the next slide. But the recommendation is that you start with macro goals, of which Laxido is one of them, and so which is why we've given that as the most optimal management option according to this guideline. And then obviously if things don't resolve, then there are other options that you can use further down the line. So hopefully that makes sense. So if we move on to the next slide in terms of looking at red flags, yeah, so, you know, if someone does come in and has constipation, don't just put it down to, ooh, constipation is quite common. You want to make sure, especially in a child, that you've kind of taken a thorough history, made sure that there's nothing to, you know, point to other diagnoses, such as, you know, when they have delay in passing meconium, if they have any kind of neurological symptoms, or significant vomiting that necessitates an, you know, hospital admission, further investigation of other things. You also want to kind of, you know, do a thorough examination as well. You know, PRs aren't commonly done in children. So, you know, that can, but it can be done under certain circumstances with someone with enough experience to kind of, you know what they're looking for, rather than just doing it for, you know, the sake of doing it, because it can be quite uncomfortable and can be inappropriate in certain situations, especially with children. So just be aware of these red flags, because that's something that's easily testable as well. So we'll move on to the next question, if there are any questions about this. So this is just a simple question. You have someone who's had a heel prick test done at 5 days old. They from that, you pick up the fact that they've tested positive for phenylketonuria, and obviously you do further testing if you do suspect the condition. But since this has been picked up, we think they have PKU. What is the inheritance pattern of this condition? I'll put the poll up now. Well done for committing to an answer. Any other takers? Okay, that's good. There's a split between C and E. I'll let you make your final decisions before moving on to the next slide in the next few seconds. Amazing. Okay, fine. We'll move on to the next question. Still split between C and E. So well done to whoever committed to E. So yeah, is autosomal recessive. I know these questions can, you know, sometimes after the earlier part of med school, people kind of forget, certain questions, but it's a very easy test question in that, final year, it tends to be more clinical oriented, but then they kind of draw you back to basic principles and basic sciences through questions like this. So a bit more detail about PKU. It's an autism or recessive genetic disorder. And so it's essentially caused by defects in the phenylalanine hydroxylase gene found on chromosome 12. And essentially it's a problem because you have phenylalanine build up, which normally would be converted to tyrosine by phenylalanine hydroxylase. And so because you have more phenylalanine, it's using the transporters that would get across the blood-brain barrier that should be used by things like tyrosine and tryptophan. So tyrosine is a precursor for dopamine, which obviously is a neurotransmitter that, has function within the brain, as well as tryptophan, which is obviously needed for serotonin synthesis as well. And so because you have more phenylalanine buildup because of the deficiency of the enzyme or the lack of function of the enzyme, then you don't have as much tyrosine and as much, tryptophan that you need. And therefore, there's deficiencies in dopamine and serotonin pathways, which is why they have the cognitive and neurological defects or disorders or outcomes that they have, which is why this can result in abnormal brain development and also an intellectual disability. So whilst we do need the phenylalanine, the buildup can be toxic. And this is not something that the body, it's an essential amino acid, but it's not something we actually make. It's something we consume. So we get this from a dietary source. And so the main treatment or the first line step in managing this is having a diet low in phenylalanine. And a low phenylalanine diet corresponds to, some things, basically having a low protein diet, if that makes sense. So there's lots of tailored regimes that can be done for this, but essentially there's a significant dietary method or dietary factor in controlling or preventing further problems from phenylketonuria. So we'll move on to the next question. I think I can't tell if it's just me that can't see the screen at the moment. Amazing. So next question is up. And so hopefully that all made sense. And we'll move on to this question now. So mom presents to ED with her 2-month-old and she's concerned about episodes where baby seems to be breathing faster and turning blue, particularly while crying, and feeding as well. Which of the following elements constitute the most likely diagnosis? So I think by virtue of the options, the diagnosis should be obvious if it wasn't already from the stem. But yeah, which of these options represent the most likely diagnosis? I'll put the poll up for that now, and then I'll see your thoughts on what you think is going on with the child. So we've got a commitment to E. Any other takers on what any other options it could be? Any budding cardiologists? Okay, so I think we're stuck with E or committing to E. So we can reveal the answer. Oh, okay. Just then we had a split between E and A. And then the answer has now been revealed, which is actually B. So sorry, guys. But I'm sure you'll still make cardiologists in the future, if that's what you want to do. To be fair, it was not my forte at med school either. So can anyone actually just tell me by putting in the chat what they think the diagnosis is? I mean, I hope it's obvious, but again, it might not be. So just for interest, does anyone want to commit to a diagnosis? I'll give you about 30 seconds to think about the diagnosis. You can also put it down as an acronym if you want to, rather than writing out the full name of the condition. Any thoughts? Doesn't seem to be. So this patient has something called tetralogy of Fallot. And so it's basically a tetrad. So 4 things, no surprises there, which is why we had 4 options of things that could go wrong with them. And so they have the right ventricular hypertrophy, they have the ventricular septal defect, and they have the overriding aorta, and they have pulmonary stenosis. So which we can see in the image there. There's some certain characteristic features. So TET spells, which is what I was trying to allude to in the stem of the question. Some things that might give it away in an exam question. They might tell you that the patient has a boot-shaped heart on an X-ray. And so those are some of the kind of pointers or things that you see in an exam question that makes you think of tetralogy of Fallot. And so it is a congenital disorder that is commonly tested. And yeah, so it's something worth knowing if you guys don't know much about it currently. So yeah, it's just something worth looking at, really. And yeah, it's quite an interesting pathology or interesting physiology when you think about why they get what they get. So it's a cyanotic heart defect, and it's caused by mixing of, so abnormal shunting, essentially, where you get mixing of oxygenated and deoxygenated blood, which you normally wouldn't get in a normal blood flow through the heart. And so you also have the pulmonary stenosis, which contributes to the right ventricular hypertrophy, because obviously there's increased pressure or increased resistance that then causes the right ventricle to work harder, which is why it gets bigger or hypertrophied. And yeah, so it's just worth knowing that, really. If you have any questions about that, just pop it in the chat. So we'll move on to the next and final question. So that is a 3-year-old brought to the GP by the concerned mother who migrated to the UK with baby recently. Reports that baby is a bit more tired, sleepy, seems to be constipated. They also have a bit of a yellow appearance to the skin. The skin is dry. She doesn't remember baby having a heel prick test being done. And what do you think the most likely diagnosis is? So I'll put the poll up for that now. Yeah, so let me know your thoughts once you've had time to read the question. About 30 more seconds to think about. So we've got someone thinking it's congenital hypothyroidism. Any other thoughts, or do we all think it's congenital hypothyroidism? We can all commit to the same answer or put any of the thoughts in. Okay, so it sounds like we think it's congenital hypothyroidism, and you are correct. It is congenital hypothyroidism. So, classic symptoms of hypothyroidism there as well. But some other things that I found this kind of acronym or kind of memory aid, which can help you think about congenital hypothyroidism. So they might have some of these features here, but essentially the one that was in our question was the jaundice, but obviously other classical symptoms of hypothyroidism, so dry skin, weight gain might be another complaint. So baby might be a bit chubby, pot bellied is one of the acronyms here with the 7 Ps. And so it's just worth kind of knowing, certain things are basic. So even though it's a child, the features listed that there are just classical symptoms of hypothyroidism. So that made it the most likely diagnosis. But the bullet points on the right are just some things that are tested within the heel prick test, which is usually done around the 5-day-old mark, which is what I've put on the screen there. So that's something they could easily ask you as an exam question. So it's just worth thinking about as well. So yeah, so that's why I've put it up there. So hopefully that makes sense. I think there was a question saying question 10, not B or C. So if we just go back to the options, not sickle cell, no, I haven't given you anything to kind of, yes, there might be some overlap in the symptoms, but actually when we think of classical symptoms of hypothyroidism, this is more likely to be hypothyroidism than sickle cell. I haven't kind of given you anything to kind of point you in that direction. And cystic fibrosis as well, I probably would have told you about, respiratory issues if I wanted you to go in the cystic fibrosis route. But yeah, the maple syrup urine disease, to be fair, as you said, you don't know much about it. I don't think anyone, well, some people might, but it's not something that we go through in much detail at med school either. So it's just one of the conditions that's tested. And if we go back to this and homocystinuria, you might need to kind of know that in a bit more detail. But maple syrup urine disease is super rare, and I've not seen it come up on an exam question ever, so you're probably safe from that end. But if we go to the final slide about the test, the reason I put it there as an option was just because the inherited metabolic diseases that are tested on the heel prick that they might ask you about easily. So even though you don't need to know much detail, it's good to know that it's tested, because that might easily be an MCQ or SBA that's asked to just know these things are tested for. You don't need to know much detail about maple syrup urine disease or MCAD. So yeah, MCAD is different, but they're all in the same inherited metabolic disease category. So hopefully that answers your question. But yeah, so hopefully that all made sense, guys. I think I've answered the questions in the chat. We didn't have many, so hopefully we've clarified all your questions, and thank you guys for joining. We hope to see you in the next session. So thanks. Enjoy the rest of your evening, unless you have any more questions, in which case we can stick around to answer your questions. We'll give you about 30 seconds. But it seems like you guys are satisfied with the answers so far. So we'll see you next Thursday.